Hello, guys. I'm Konstantin German. I'm one of the second-year fellows at the University of Cincinnati in cardiology. I'm really excited to do this talk for you.
Hi, everybody. It's Jen Cook, cardiology, advanced heart failure attending, frequent present in CVICU-B, and we're really excited to bring you another installment of our CVICU primer series.
So, the goal of kind of having this conversation, kind of having these primers is to, expose you a little bit to some of the things that you may not see in other places in the hospital. I know starting off as a resident in the ICU, I was kind of bewildered by some of the devices that are going on. So this is kind of a way to, talk to you about, why we do them, how we do them, what are the situations that we use them in, how are they helpful, if at all. So some of the objectives of the talk today, we're going to talk a little bit about, the role of mechanical support in our patients and kind of the situations where you see them used most often. We'll talk about kind of the basics of, how do you put them in, how do you keep them going safely of balloon pumps and impella support devices. We'll talk about some of their physiological benefit, and also talk about, unfortunately, a lot of the complications that these devices have. They're oftentimes a necessary evil in some ways, but they can be very helpful in some, carefully selected patients. So what we always like to do is kind of make this a clinical situation. So, this is somebody that many of you guys will see present during your rotation in the ICU. So a 63-year-old male with a past medical history of hypertension, diabetes, dyslipidemia, CKD stage 2, presents to the ER of chest pain. Vitally, their temperature is 98.6, blood pressure is 139/79, their heart rate is 92, and they're 95% on room air. You have an EKG that shows sinus tachycardia with some T-wave inversions in the anterior lead. To get a troponin, it's 1.2, and 6 hours later it goes to 18, and the patient's still having chest pain. So what do? You call the Cath Lab in, and this is what things look like. So for those of you that are not completely acquainted with coronary angiograms, I just want to kind of go over about what we're seeing. So this is a catheter that's engaged into the left main, and distally in the left main, you can see a very significant, probably an 85 or 90% blockage. And this is kind of another angle, that same situation. In these patients who are diabetics and have left main disease or proximal LAD disease, there's a lot of evidence that points towards surgical revascularization rather than stenting. So what we may do sometimes is actually not stent them, actually medically optimize them before they can go to surgery. But that kind of involves, a few ducks falling into place. So those patients on the table, you get your images, you have your diagnosis of coronary disease, and you're trying to figure out what to do with them, and you're trying to get them chest pain free. In the meantime, you put them on nitroglycerin drip, and slowly their blood pressure drops. So this is a kind of an expected effect of nitroglycerin. And now their blood pressure is 90/62, and they're still having 6 out of 10 chest pain. And this is kind of where you call your friendly neighborhood clown to put on the balloon. So, this is a kind of a silly visual of what it is, but a balloon pump really isn't much more complicated than this thing right here. So an intra-aortic balloon pump is a frequently used instrument in many ICUs around the U.S. We can kind of talk a little bit about them here, and kind of talk about the indications and what are the benefits and what are the cons of these devices as well. So some of the indications, you can have them in acute myocardial infarction as a way to kind of help support blood flow to the coronaries, and cardiogenic shock, and it can help offload some of the work of the heart as well as kind of add to your cardiac output and index. In the acute mitral valve regurgitation, you can kind of use its ability to decrease the work of the heart and reduce afterload to help our patients there. And we also sometimes use it in high-risk PCI. There's a couple of other indications that are listed there that are less common, but the ones that are underlying there are things that you're pretty much for sure going to see at some point during your 3 years of residency here.
One of the things I can say for sure is that the intra-aortic balloon pump is probably the device that's been used the most. So if you are talking to the interventional cardiologists, this is something that we've been using for years and years. And so it's something that's available in every cath lab across the country, and all interventional cardiologists have a lot of experience with it. So I think that you think of it as kind of the workhorse of mechanical support in the cath lab.
Absolutely. I think it's really a good place to start off the foundation of learning about these devices and some of the interesting physiology that's involved in cardiovascular disease. So just to go back to the basics, it is simply a balloon. It's a pneumatic device, meaning it blows up and it comes down. That's all it's really doing. But it does some pretty cool things. So one of the things that it does is it creates diastolic augmentation, which essentially it raises your diastolic blood pressures, and that's really important for what your coronary arteries see. So with more pressure, you increase coronary perfusion. And there's some very limited evidence that increases cerebral perfusion. When we put these in, it's not for cerebral perfusion. Typically, it's for coronary perfusion. There's also a good amount of afterload reduction, like I mentioned previously. It decreases the LV wall stress and increases the cardiac output, from 0.5 to a liter per minute, which can be helpful in patients that are, not so ill where they're kind of at the end of the rope, but they're kind of on more of the border. You're trying to kind of get them up a little bit and give them the support they need to get them over the edge. Regarding the placement of these, typically these are put through the femoral artery. I think 90+% of the ones you see here will be put through the femoral artery. Occasionally you can do them through different destinations, but this is the one you'll see most often. Essentially, there's a pressure tracing that can feel the aortic pressure, and there's also a kind of a sausage-shaped polyurethane balloon that stays in there. And the whole goal of that, the design of that is to avoid clotting if at all possible. Any sort of foreign object in the body is prone to get clot, so we want to prevent that, especially on the arterial side, if at all possible.
Constantine, would you go back 2 slides for me? There's one comment I want to make. So one of the things that I like to do when I'm teaching at the bedside for people that maybe haven't been exposed to a balloon pump before is that if you think about it, the balloon pump is going to blow up and deflate with each cardiac cycle. And so what's happening is after the aortic valve closes, the balloon pump inflates. And when it inflates, it sends blood both proximally and distally. You can go to the next screen and show the picture. So there you go. So when it inflates, it sends blood proximally and distally, and that's where the coronary perfusion happens, because you actually have positive pressure in the aorta that's leading to blood displacing out of the aorta. But the interesting thing that happens is that when the balloon pump deflates, it creates a potential space in the aorta. So, of course, I think like a heart failure doctor, and I think about afterload a lot of times. Oh, and there's my golden doodle. Sorry about that. But
I think it's called a special appearance.
He's excited about cardiac physiology as well. But what happens is that when the aortic valve opens, instead of opening up to a mean arterial pressure of 80 millimeters of mercury, it's opening up to a mean arterial pressure of essentially 0. And so if you can imagine, if you have a ventricle that has a left ventricular end diastolic pressure that's elevated, that then when the aortic valve opens, there's this potential space. It unloads the left ventricle and allows for an increased stroke volume for a certain degree of left ventricular dysfunction. And so I just like to spend just an extra minute in talking about the physiology there, because I think that as you showed on the slide, that it increases coronary perfusion and decreases afterload. That's precisely the way that it does both of those things. So I'll let you go on and talk about the placement here.
Yeah, it's incredible we can get all that accomplished really from a simple balloon blowing up and coming down. It's a really pretty neat thing that's been thought up of, and so many people around the country use this. It's really a neat little toy that we use in the ICU. The other thing that's really critical is the placement of these. Like Dr. Cook mentioned, these kind of blow up and go down, and you have to kind of make sure that it's doing it not only at the right time, but also in the right places. So here's an illustration of kind of the proper placement. It has to be about a centimeter distal to the origin of the subclavian, because you can imagine if you have a balloon blowing up here, it can cause thrombosis and potentially ischemia. And there's some pretty important vessels here, including your carotid coming off here. So what we try to do is make sure that none of these vessels are affected. And also, if you don't put it in quite far enough, it can obstruct the flow to your renal arteries, which can cause AKIs and all sorts of issues with your kidneys. So these are all the sort of things you want to kind of ensure don't happen, and why we often get daily x-rays to make sure they're in the proper spot and have not moved. And you can see an x-ray here that shows a proper positioning of the balloon pump. So we tend to get these every single day on our patients with balloon pumps. This kind of speaks to what we discussed earlier. As this blows up, this column of blood gets kind of pushed back, and your coronary arteries actually come off of here. And that column of blood and the increased pressure can kind of go through some narrowing in your arteries and provide the necessary blood flow your heart needs to function appropriately. And then here in systole, as the LV is contracting or as it's about to contract, the balloon deflates and creates this, column here where the pressure is functionally zero, really leading to a nice kind of effluent reduction, helping your LV quite a bit, moving things forward. This is kind of what it looks like, where you have the femoral access and it's connected to a console that kind of shows the pressures over time, and also shows you any issues or any trouble alarms will come up on there as well.
It is also possible to put a balloon pump in the axillary artery. It's much less common at UC for us to do so, but sometimes this is done for patients that are awaiting heart transplant, that there's extra benefit of being able to get them up out of bed. So if you see an axillary balloon pump on your rotation this time, you'll be lucky, but it's something that can be a sophisticated way as well.
And that's a really good thing to kind of let your patients know about too. When these things go in, you're kind of stuck on your back for as long as they're in. You can't really sit up. You can't do much of anything. You're kind of stuck in that position. And, for people that have things like chronic back pain, it really becomes difficult to maintain because all they want to do is move. And that's one of the issues that does come up when you have somebody on a balloon pump for an extended period of time. Like a lot of the things we do in medicine and a lot of devices, when they go in, we right away try to think of strategies how to get them out, but unfortunately it doesn't always happen that quickly. And sometimes people have to be in the balloon pump for some time and it's not the most comfortable. That's just, kind of what they have to deal with to get through the acute illness. There are times, like Dr. Cook mentioned, where the axillary balloon pump is more comfortable for the patient because they can kind of move around, but we don't see them very often here. Important to know, besides the indications or some of the contraindications. So if you can imagine, as you're putting the balloon pump up the aorta, any sort of thoracic or abdominal aneurysm, you don't want to poke that through that. Any sort of really, defect in the aortic wall is potentially problematic, including dissection. The aortic insufficiency is a really good and one of my favorite, I don't want to call them pimp questions. Let's call it educational pearls that I leave on people. The way that this works is when the balloon pump inflates, that column of blood kind of has to push against something to generate that pressure. That's the aortic valve. And if you don't have a competent valve, basically all that will happen is that blood will just get pushed back into the LV, which will get, that pressure is going to get transmitted back into the lungs. You can actually cause pulmonary edema if you're not aware of this patient's aortic insufficiency. So anything above mild aortic insufficiency, I believe, is a contraindication to using a balloon pump because it may cause more harm than help. So one of the things you always have to do before you put this in is rule out aortic insufficiency with an echocardiogram. If somebody has severe peripheral vascular disease, you can imagine snaking up a big catheter through a lot of calcium may cause a lot of shearing and potentially lead to ischemic limb or perforation of arteries. So if you have very severe peripheral artery disease, you may not be able to get a balloon pump. And sometimes what you'll see is people choose alternative access because let's say somebody has lower extremity peripheral artery disease, but maybe their axillaries are okay. And that's another reason to go axillary over femoral. Someone for severe cardiomyopathy, once again, this is a big, sheath going in and large access. We always want to be, wary of that when we're putting in our devices in coagulopathic patients. And sepsis is always a concern. This is a foreign object that's going into the body. So anything that is not part of your body is more susceptible to infection. And if someone's bacteremic and they have a foreign device, and they can seed bacteria and cause more harm than good. So these are the big contraindications. You kind of quickly go through your head before you decide, hey, yeah, this is a patient that should get a balloon pump. There's always the risk. So the figure that I saw listed is about 20 to 30% of them have complications of some sort. I think that number is a little bit higher than what I've seen clinically. But these are things that we don't use them for people that don't need them. We only put these in when people really need them because there is that risk of limb ischemia, thromboembolism, aortic dissection, and infection. The older you get, if you have worsening peripheral artery disease, the longer the device stays in, and other factors like diabetes, hypertension, depending on how sick you are, how much vasopressor you need, kind of raises your risk for these complications. But these are things to look out for. So if your patient has a balloon pump, you do want to check kind of their legs and what things look like. Are they mottled? Are they purple? How are the pulses? because these are big issues that can come up with these devices. We want to make sure we're giving the maximum possible benefit without, giving any harm to our patients. This is kind of what I mentioned earlier of the console showing the pressures and the telemetry. Regarding the timing, the balloon pumps could have different settings. So basically what you can say is on a 1-to-1 setting of every heartbeat, we want to deliver an inflation, as opposed to 1-to-2 is every 2 heartbeats gets an inflation, as opposed to 1-to-3 is every 3 heartbeats gets an inflation of the device. And the reason you kind of choose different settings is based on the amount of support that you want to provide. So a patient that's very ill, you'll always put on 1-to-1. As you think about weaning the support, rather than just pulling out the device, what you want to do is drop that support for 1-to-2, so they're less reliant on the balloon pump, and see if the patient can maintain their hemodynamics by themselves. If that's going okay, some of us will remove it then, or some of us may choose to do 1-to-3, which is almost really no support, but it doesn't pull the actual device. The reason we don't turn it off completely is the more stasis there is in the device, the higher risk of clot. I should also mention that when you're in 1-to-1, you have to be, you don't have to be anticoagulated. Once you drop to 1-to-2 or 1-to-3, you absolutely have to be anticoagulated because your risk of thrombosis is high. You can be triggered by the EKG, so the EKG can kind of tell the balloon pump where we are in the cardiac cycle and when to inflate, or it can work by pressure. Oftentimes we do it by EKG. I think outside of things like AFib with RVR, that's fairly reliable. Whenever you do have arrhythmia, such as AFib with RVR or any sort of kind of fast rhythm, the efficacy of these devices slightly goes down, or quite a bit, depending on how fast you go and how irregular you are. So having a patient with AFib with RVR, it may be beneficial to drop them to 1-to-2 to make sure that there's more synchrony kind of between the cardiac cycle and the balloon pump, rather than you kind of have flopping around, which doesn't really do a whole lot of anything. But those patients are really tough, and maybe the balloon pump is not the best option for them. But these are all things to kind of be aware of. So 1-to-1, that's full support. Do not have to use anticoagulation. 1-to-2, 1-to-3, less support, and you absolutely have to have these patients anticoagulated. We typically use unfractionated heparin to achieve that. This is what we kind of talked about earlier. The inflation, it pushes the blood towards the valve, increasing coronary perfusion. The timing is also important. So if the balloon inflates early, what happens is as the LV contracts, it goes against an inflated balloon, it actually increases the resistance and decreases your cardiac output. So the exact opposite of what we're trying to do. And you can actually figure that out by looking at these line tracings right here. Here's a nice normal one. And you can see that in this one, the balloon inflates earlier in the cycle. So it inflates around here rather than being right here. And that can decrease your cardiac output and kind of increase your afterload. If you have late
the early inflation and the late inflation, a lot of times can happen just like you described when you have a variable R to R interval. Like, for instance, if there are lots of PVCs, PACs, or AFib with RVR. And so you might see a combination of good timing and then early and late inflation with a variable R to R interval.
Yeah, so if this happens often enough, you may be actually hurting the patient rather than helping them. That's an important thing to know. When are your devices working against you? If you have late inflation, it just lowers your systolic pressure. I mean, it kind of comes on, but it doesn't really accomplish the goals of what we're trying to achieve. If you have early deflation, remember what really helps is that empty column that right as the LV is contracting, if that column is kind of refilled with blood, we kind of lose the benefit of that afterload reduction. And that's not, as beneficial as what we could have otherwise. So that's another, problem you could run into. And then there's late deflation, which is essentially, it stays up as things are contracting and basically increases your afterload and your myocardial consumption, which is not ideal in settings of acute ischemia or cardiogenic shock. So these are all things that not only is it does it turn on, but when does it turn on? That's really critical in making sure that these devices work appropriately. Now, you're all doctors now. You're grown up. So what you need to be doing is asking, show me the data. So all of these things theoretically, sound great, but you kind of have to look at the research and kind of what has been studied and what has not been studied. So this was a study that's actually the short name for a Shock 1. It's something to build on. It's more of a historical perspective, where in this study there were patients that had an MI, and it was a question of, should we revascularize them or should we use medical therapy, including fibrinolysis? And in this study, about 86% of people had some sort of balloon pump that was in place for the revascularization. There were some exclusion criteria, like a severe systemic illness, different types of shock outside of cardiogenic shock, severe valvular disease, dilated cardiomyopathy, or if you couldn't revascularize them, they couldn't be in the study. The inclusion criteria is good because this kind of is what's built on in Shock 2, which we'll talk about that in a second, where what they're looking for is cardiogenic shock with acute MI. And these are some of the EKG criteria, things like ST segment elevation, Q wave infarction, new left bundle branch block, posterior infarction was also included. And then, I think in some ways, more importantly for this talk is how do we define cardiogenic shock? So here they need to have hypotension, which is a systolic of less than 90, or pharmaceutical measures that were taken to keep the systolic above 90, evidence of end organ hypoperfusion. And then if you have SWAN data, it will be a cardiac index of less than 2.2 and a wedge greater than 15. So these are the patients who are included in this. And basically it was looking at the difference between early revascularization versus medical stabilization. And what they basically saw is that PCI in these patients is really helpful as opposed to using fibrinolysis. Then what they did is they took the results of Shock 1 and did Shock 2. So easy to follow.
Can we go back to that one for just 1 second? One of the things I think is so fascinating about this is that we need to take a look at the y-axis here. And so we have days after randomization. So these are inpatient outcomes. So this is not, this is basically survival to discharge. And do we notice, take a really close look at the proportion alive?
Yeah, that's a great point. I mean, it's these are pretty scary statistics. On the medical therapy, you're looking at about half of people survive at 30 days, and the better outcome, revascularization, we're looking at maybe 55%. So it's not. These aren't 80-90% of people are surviving. They're very, very sick patients that have very kind of grim prognoses.
Exactly. And so I just had to stop and pause to point that out, because sometimes when we are taking care of these STEMI shock patients, we don't realize that they really have about a 50-50 chance of leaving the hospital.
Mm. Yeah, no, that's a great point. I think that's one of the things that as my training has gone on, I've been more open with my patients. Where recently I had a patient that came in shock, got a balloon pump, and the family asked me, "Doc, what are the odds?" And I told them, 50%. And those aren't numbers that you like to give, but surprisingly, shockingly, should I say, they were really kind of appreciative of the honesty. And fortunately, this patient fell on the right side of the 50%. But these are very, very sick people, and as a whole, don't do very well. So we're kind of looking for 5 to 10% differences, but as a whole, about half of these folks do pass away within 30 days. So that's a really great point. Thank you for bringing that up.
And from my perspective, the reason why this is so important is that if we support a patient that's got cardiogenic shock and perhaps end organ hypoperfusion before they end up on dialysis and with all-out hepatic failure, we can VAD and transplant those patients. And so the mechanical circulatory support and early intervention is so important, so that we have patients that have adequate cardiac output to maintain end organ perfusion so that they can qualify for advanced therapies. So, this is just part of the classic teaching that I have at the bedside, and that, we co-manage sometimes, with the CVA ICU A team, B team, we all work together on these most complicated cases. But this is one reason why you'll see the heart transplant docs be extremely aggressive with cardiogenic shock and move to mechanical circulatory support really early in anyone who's requiring any type of pressor support.
Absolutely. Thank you for bringing up that point. And you guys will see on CVI A and B, these conversations happen pretty early in the hospital stay. We don't wait till day 10 to consider balloon pumps. These are things that we thankfully pull the trigger on fairly early to give our patients a fair shot of hopefully not needing that advanced support, but if they do, maintaining their candidacy for it, which is a really important point to bring up, and something that's really, I think, kind of unique to the CVICU, where we have all these toys to kind of make sure that we have a plan A and the plan B, and sometimes unfortunately a plan C. And it's nice to kind of talk about that on rounds, and some of these devices buy us time so we can have those conversations and make those arrangements for patients that need it. That's a really great point. Which moves us along to shock 2, which I would love that at the end of this talk I had this amazing data where balloon pumps can give you this 90% mortality benefit, but in this specific study it's not really what we saw, where these were patients who had mechanical support for cardiogenic shock with a balloon pump. And in these patients, the balloon pump did not fare better than medical therapy, where you can kind of see the mortality curves kind of, pretty much are the same. Now, it's a very important point to make. And I think the mortality of this study was about 40%, where typically in studies you see about 42 to 48% mortality in their patient groups. So this could be a less sick subset of patients where using these balloons maybe did not have the same effect as they do. This is why we're so careful to only use the devices where we really feel like these patients have no other options, and this is something they absolutely need, rather than kind of, I think, throwing them in early, I guess, too early or before someone is really ill. I don't know if you could speak a little bit about this trial, Dr. Cook.
Yes, so shock 2 was long awaited because there was a lot of debate about whether or not balloon pumps were necessary, and they were in fact compulsory for any patient that had an angiogram like the one that was presented earlier in this talk. Anyone with left main disease automatically got a balloon pump. Anyone with triple vessel disease automatically got a balloon pump. And there were a lot of questions over the years about whether or not that is something that there was evidence for. And so shock 2, when it came out, was very anxiously awaited. And then when it showed to be no different between the control group and the balloon pump group, it really led to a lot more questions. And one of the things that investigators thought is perhaps the issue was that the balloon pump didn't unload the patients enough. And in a separate talk today, we're going to be talking about Impella, and the question of whether balloon pump just isn't enough and that the patients need mechanical circulatory support. But I would say that the mortality here of 40% is improved from the medical therapy arm and the balloon pump arm in shock 1. So in that decade of support, the decade of evolution in the field, we did see some improvements in outcomes. But I would say that most people were surprised by shock 2, and still it's referred to as a trial that suggests that balloon pumps may not be indicated in STEMI shock.
Right. So the evidence here is one trial. You will still see them selectively used in patients. I recently had a patient that had a cardiac index that was 1.2 on 5-dobutamine, and the only real option he had for mechanical support was a balloon pump, and he I don't want to say magically, but drastically improved. And they're really pretty neat devices that in a carefully selected patient I still think do benefit. But to my knowledge, I'm not sure if we've had any big studies showing a big balloon pump, the RCT or anything like that, that's shown a big difference, balloon pump versus not. I'm not sure if we've had that, but I think clinically we try to kind of carefully select patients that we think will benefit from them and use them, wisely.
Absolutely. And we know that there are some super responders to balloon pumps, just like the patient you described. And one question might be, is it that it's the effect of the afterload reduction that's really making a big difference in the patient? Or perhaps it's the coronary perfusion and somebody that has that's ischemic, and then by reversing the ischemia, you have improved contractile function. But finally, remember, the size of the balloon pump is indexed to the size of the patient. And so it might be, if you have a 6'4" gentleman, that a balloon pump just isn't supporting nearly as much as if you're putting it into a 5'2" female. And so there are lots of factors that might be playing into this. But in general, it's thought that if patients aren't improving on balloon pumps, it's because it doesn't provide enough support.
Perfect. So that wraps up our talk on balloon pumps. You guys will see many of these. I encourage you to try to go to the bedside and take a look at the console, take a look at the waveforms, talk and think about the physiology of these neat devices because I think when used appropriately, we've seen really great response, and you will still see them used fairly frequently. I would be really surprised if no one saw this in their time in the CV-ICU. So they're good to know. They're good tools, and they're something unique that we use in the cardiac ICU that you won't see many other places. So it's a really good place to kind of wrap your head around the device, the physiology, the anatomy, and kind of pick your fellows, pick your attendings' brains about these neat support devices that we have.
That's terrific. Thank you so much for this review, and we're going to sign off for right now, and you can tune in for part 2 on Impellus.
Awesome. Thank you.